first of all, how can I ask someone from the team how you felt the team worked in general? Anyone?
I suspect the team worked very much like our team would work in recess. There was very little actual discussion about what was needed because we all just kind of get on with it, which was a bit difficult to try and demonstrate it.
It's always a bit nerving when you've got an audience like this and cameras happening. Have you all worked together before?
At times.
Yeah.
Mm-hmm. Okay. So you're all from the same emergency department at the same hospital. But I think the roles are pretty universal, aren't they, in emergency departments? Yeah?
Yeah, they are.
I think so.
Yeah. So did you feel you easily fell into those roles? How were the roles allocated?
So we had our medical staff allocate roles between themselves and nursing staff. I think we fell into them fairly easily. We just had to double up a bit because we sort of had a suboptimal team numbers, but managed to divide them up appropriately.
Right, okay.
It's nice to have that couple of minutes beforehand to work out who's going to do what, so you know who you're asking for various things.
Right, okay. And I guess you don't always get that opportunity.
No.
No, we don't always. We do probably the majority of the time for big recesses like that, but not all of the time. But that preparation time is invaluable.
Okay, all right. What do you think were the strengths of the team in managing the case?
I guess calmness and just quietly getting on with it, no running around being shocked and horrified and terrified. Everyone just knew their job and did things and suggested things that had been forgotten, which is how it always works.
We had good direction from our team leader as well.
Yeah.
So
Okay.
Having a clear team leader who takes that directive role, I think makes all the difference in a recess room.
Right, okay. So the team leader seemed to emerge, but not necessarily with anyone saying, I'm going to be the team leader. So how does that evolve?
In real life, the team leader is the most senior person in the recess room who sort of stands up and says, I'll be the team leader. In this simulation, I guess it was always going to be me.
Okay.
we tend to know that
But
as well.
I think because we know each other, we know that would work. If it was a room of people who didn't know each other and we actually had no idea of everyone's strengths and weaknesses, it would probably be better if we'd had very much a who's going to be team leader discussion.
Right, okay.
Yeah, and we sometimes need to do that, but sometimes it's obvious who needs to be team leader. And in a recess situation, if we would have had the full team, the team leader would generally stand back and just team lead. It's a bit difficult for Louise because she had to do a couple of roles, but I think the team leader role still came off well.
Right. So it flexes up and down depending on the number.
And also depending on who else you have coming into the room. So if we needed a surgeon or an anaesthetist or someone else coming into the room, then probably the team leader would stay the same, but the role would change slightly.
Right, okay. And teams, the members of teams, they understand their roles once they've been allocated?
Yeah, well, the nursing roles are really well defined, and the nursing roles are, you have an allocated role once you start your shift, so you know that if a resus comes in, you're going to be you're allocated to that role for your entire shift. So you're in charge of checking all the equipment for that role, and when a resus comes in, you go straight to that role and start working.
Okay.
For the doctors, it's a little bit different. Their roles get worked out when a resus gets called and they come into the resus room, then the roles get divvied up. But the nursing staff is quite structured, I guess.
And within those roles, do you then have a set position that you take up around the patient?
For nursing, we do. Generally, the airway nurse would stand where Brett stood, and the scribe would stand on the other side of the bed where I stood. And then the B-roll or the drugs nurse would sort of stand at the end of the bed and work either side.
Right, okay.
And certainly, doctors, it's much less prescriptive. There's usually a team leader who stands at the foot of the bed and just can see everything, doesn't touch the patient. Then there'll be an airway role who stands at the airway and checks on that and keeps that fine. And then you have a circulation and a procedures doctor.
Right.
And poor Holly had to be both of those.
Okay.
We tend to move around a little bit more. I mean, so...
B and C walk around a
Yeah.
lot. A stays still and T and E stays still pretty much.
Right,
Yeah.
right.
Yeah.
So it seemed to me that you were an experienced team who knew where to stand, what roles to undertake. How did you feel about the communication amongst the team?
We were quite quiet, I think. We were sort of just doing what we knew we had to do, and so we were quite quiet. But I think there was clear communication when we were asking direct questions. Do you want that drain in? And Louisa said we need to get that in quicker.
Right.
When I went to assess the lower limb, and then Louisa said, no, can we get that fast scan?
Okay.
Yep, so I can do that now. So there was direct questioning and direct response, but not much chit-chat. I think in reality we'd probably have a little bit more noise, a little bit more talking.
Yeah, certainly much louder. With regards to giving drugs and fluid boluses and that type of thing, we normally try and be really vocal about that. So if we didn't give any drugs this time, but if we gave 5 milligrams of IV morphine, we would say 5 milligrams of IV morphine in, because that's so the scribe can hear it and get it down.
Right, yes. That's a really important aspect of closing that communication loop, isn't it? Right. I think you've done some simulation team training before, is my guess. Was it clear, do you feel, the relaying of the message to whom? So when you were giving directions, Louisa, was it clear who was the recipient of those instructions?
I thought so. I normally try and direct using a name if I know a name. I don't always know a name,
Right.
but normally I try and make it a you. Can you do this for me?
Right,
Can you do that?
okay.
But I think
We tend to paraphrase as well.
Yeah.
So if I've had a direction towards me, I'll paraphrase it back just to get clarity.
Right.
And that's usually what happens in a resus situation.
Excellent.
Yeah.
Yeah, that's a good way of making sure that that's the person the message is intended to and they've received it.
yeah.
Great.
And the correct message as well.
Correct.
Yeah.
Great. I think we'd all be happy going to this emergency department. I'd like to now ask about the handover from the ambulance officer. So Ronan, would you like to just come up for a little bit? And I'd like you to tell us how your handover was. Do you think it was, complete? Give me some...
I'm sorry. I guess as a handover goes, it's probably a reasonably typical handover from paramedic to an ED department. I hope so. I guess the critical information is the mechanism of what happened. Also then, how we found the patient. So in other words, the GCS consciousness level, evaluate that. The primary survey, secondary survey, anything identified, and then whatever interventions we had to perform, such as cold intubation, whether the GCS was varied, maybe we would use, for RSI or whatever. And then the fact that we tried to get some fluids in because the BP, obviously the patient was hypotensive. We had to take care of any of the bleeds, etc., as part of that secondary survey follow-on. So I hope that I addressed most of those points in the handover and was as reasonably direct as I could be when I met the team.
So let's see. Can I get some feedback for Ronan about... No, stay here. About his handover. Did you get enough information to then work on? You also had the preliminary phone call through before arrival. So was it enough information for you to prepare?
It's the amount of information we normally get.
The amount of information they normally get. So that's good. Okay.
It was all the information we needed. We knew that it was a child, which was important for us in our preparation phase.
Right.
We knew that they were GCS3 and that they were intubated and ventilated. When they're intubated and ventilated at the scene, we know that there's been no drugs involved, so we know that it's going to be serious. And we knew from that immediately we needed to call a trauma call. So I think we got all of the information that we needed.
And we knew the weight, and we knew that he was, well, we knew the age, therefore we could guess the weight and we could work out what drugs we'd need on arrival.
Right, okay. Thank you, Ronan. Okay, I'm going to move now to, as a wrap-up, as a general overview, the team seemed to be well prepared, functioning very well because you're familiar with it. You had defined roles and you were prepared for arrival of the patient. Then we had the social worker, Trish, bring mum in. Is this something that usually happens in your workplace?
With a paediatric resuscitation, certainly with one where the prognosis is that bad, we'd normally get mum or a parent involved so they can see that we're doing everything and they're involved. And I don't know, if it's far less serious and mum might be a bit more of a nuisance, then we try and keep them out of the way. But I think most doctors would get mum involved when the outcome's likely to be that dismal.
Right.
As long as they're supported in the resus room with preferably a social worker.
Yeah.
Right.
Just so
okay.
they can see that, you know, everything is being done. And
Yes.
And certainly there's a move for getting mum, dad, someone in when there's CPR going on in progress. So it just helps
Right.
closure later down the track rather than anything
yes.
else.
And I think the support is really important. So what if there was no support around for someone to stay with mum?
Probably slightly more tricky because you need to know that mum isn't going to throw herself across the patient and get in the way and actually hamper resuscitation efforts. So probably if there was no support, you wouldn't get them in necessarily.
We do need some explanation from mum as well because things are happening. We know what we're doing and we're not always communicating and explaining, or explaining in our terminology. So mum or dad need a bit of a reassurance and explanation about what's happening.
Right.
And there might not be someone to say that.
Usually in our scenario at Gold Coast, a lot of the time the team leader for the shift will take on that social work role, and there is none after hours. We have had limited training in that field, but you know, we make do with what we've got, and you know, there's really good resources support, so it's great to have the family in through paediatric resus.
So you've raised a really good point, Brett, and I think that's an area that can simply be used as a focus to develop your communication skills on how to support mothers or parents during paediatric resuscitation. It's hard to know what to say, so rehearsing it is really important. So that's a key area I think anyone can do. Now, mum and the social worker. So, Trish, when you came in, how did you feel the team responded to your request?
Pretty well. I mean, I knocked, I think, I'm not a social worker, but I'd imagine from my observation of social workers that they understand the role of the doctors and nurses is to look after the patient first. So I knocked on the door and said who I was and told them what would happen and sought their permission rather than trying to say, here's mum, because I think that would have been really unfair for them to bring mum in and say, here I'm the social worker, here's mum, you deal with it. That doesn't respect their position. All that. So I tried to sort of make it that they could do their job and concentrate, but understand that there's that whole extra layer of messiness and complexity of the family and what's happening. So I tried to sort of do that and then bring mum in as best I could and prepare her, but nothing can prepare parents for what they're going to see. It's all pretty hard.
Right. So for the team, that's a critical part for someone to ask, when is it appropriate to
Very
bring
much
a
so,
parent in?
yeah. Often, you know, she came in just as we were about to do a chest drain and try and stabilise this child, which wouldn't happen. Wouldn't happen in a real scenario. We'd normally say, look, hold on 5 minutes, we'll just get everything looking a bit better. But then you have to have in the back of your mind, what if it doesn't get better? What if the child just dies? And it's much better for mum to see before then.
Right.
So you kind of want to balance the whole messy scariness of everything with a bit of a...
So this is an important skill for more junior doctors to develop and understand and observe and integrate into their practice. So in the emergency department, would you have more junior staff observing this expert team performing?
We'd normally have 1 or 2 more senior doctors in a resus team and then 1 or 2 more junior doctors. So normally you'd have your residents getting IV access. So they're in there, they've got a job, but they're not doing the sort of more technically difficult airway role, particularly.
We will one of the more junior staff members. So I'll be in there doing things, the simple things like access, getting the blood, running the blood. And so you have a role, it's very defined, but you can also, while you're doing what you have to do for that patient, in the background of your mind, you're paying attention to what your seniors are doing and how they're managing things and how they're communicating. So the whole process of having that role is also learning, so that one day you'll be doing the other role as well.
I think you can't underestimate the power of people seeing practice being modelled in the way that you've just demonstrated.
We've identified that, and in the development of the new Parklands Emergency Department, I know at Robina as well, we've actually got cameras that stream into the resus rooms now, and you can sit in the tutorial rooms and watch them live.
Right.
So we've identified there is a very big educational component, so we can't wait to get the new pace.
Excellent.
We also use resus. We also use simulation training quite a lot, so the juniors have more exposure to the team leader role and various other things. With that.
Excellent. Good. And is that in situ or right? Okay. Now, last but not least, we're going to come to Mum. So, Mum, when the social worker brought you in to the scene, did you feel part of the scenario? Did you feel you were given enough information? Just tell me how you felt when you came in and saw your son on the stretcher.
I guess it was particularly overwhelming, and so I'm not sure what the doctor said to me. I can't recall what she said to me. I just remember asking her to look after him. It's pretty confronting seeing your son lying there, having sustained those life-threatening injuries, and I think that for a parent, I'm not sure that they would actually take on board what was actually said to them. There was a lot of medical terminology. I didn't understand any of that. But then the social worker took me away because I just found it so overwhelming, and she was explaining things as I walked away, but again, I still can't recall that conversation.
Okay. And that's an important cue to look out for, I guess, when the parent has had enough and it's time to go away. Always potential to come back though, depending on how Mum wants to interact. The important thing to consider in all of this, and I'm not sure whether you ask others who are playing roles, etc., whether anyone has personally had these types of experiences. So whether they're okay with taking the role of the mother. So I hope you were very authentic in your responses. So that's something just to check, if you're doing this type of role play with a mum. And certainly we do with undergrad students. You just need to check, because this is such an emotionally charged and powerful type of learning experience, you need to just check the effect that it's having on people. And key managers of the university who come in and have a look at our very simple role plays are affected, and we don't anticipate that. Okay, I'm going to now open up to the audience. We've got a few more minutes to have some comments back from people about the team's performance overall. Do we have, and Dean has a roving mic at the back. Would anyone like to make a comment about the team's overall performance? Can be anything, communication, roles. This lady here.
Thank you, that was awesome. My comment is, when we talk about communication, throughout that whole process, somebody mentioned, I think it was you, the lady in the purple, have we checked the pupils? When we got the handover as GCS 3, we'd done everything, and then, somebody said, oh, okay, what about the pupils? And oh, yeah, that's a good thing. And then you check them. So it's about that whole team environment. And things do get missed, so that's why as a team we need to prompt and help others through their roles. So good work.
I think the primary and secondary survey are just the mainstay of working through. But it does highlight a really important point that in all the excitement you can skip over something, so it's worthwhile going back and checking. Okay, any other comments? Questions?
Hi, I was just wondering.
Yep.
I was just wondering, I've heard that in some cases through simulation training, people will put people in not their usual role. So, for example, a medical student put in the most senior sort of decision-making role. Does that have a place, and I guess how is that utilised?
I think it depends what your learning objectives are in the whole simulation. I'm going to throw to Louisa for this one.
I do some simulation training with the university, with Griffith University, and then it's much more about clinical knowledge teaching rather than teamwork teaching. Because I think in order to teach a team dynamic, you need to have people doing their own roles, so they know what they're doing, and the clinical knowledge is secondary. If you're teaching medical students how to do a primary survey, how to do a secondary survey, they're all going to be the same level, so one of them is going to be the team leader, and they're probably not going to have any more clue than the others. But they do learn during that they're allowed to talk to each other and they're allowed to do things. So I think it's very different. If you want teamwork skills to be practiced, then you need to have people doing their own roles.
I know with our simulation training that we do at work, it's very much focused on not on the clinical aspects of the simulation, but on the communication and how the team works. So we've often used a nursing student or a medical student to be involved in that as part of the team, not as the team leader, but as part of the team.
And sometimes we will have more of the senior junior staff, if that makes any sense, acting in a role as team leader, or rather than one of the more senior staff doing that.
But they have to know roughly what they should be doing, or the whole thing falls apart. I did do one simulation, and we didn't have any nursing staff, so I had 3 medical students being nurses, and that was hopeless. It was utterly hopeless.
So were you meaning cross-discipline or within level of experience within a discipline?
I probably heard that within discipline, but different roles.
Right, okay. And there are varying opinions about it. I think certainly within discipline, there's benefit in exposing people to the responsibilities and the pressure of a time-critical situation like we see here. But cross-disciplines, as Louise has just said, there's not enough, I think, understanding of the role of a nurse for a medical student to play, and vice versa. You want authentic types of responses from people. But look, there's varied opinion on it, and you can try it, and people will come to their conclusions that that didn't work so well. So I think in SIM, there's good practice guidelines for delivering and developing simulations.
The question that related to other health professional or health professionals swapping roles within a simulation. I'm involved in a very small piece of work with some colleagues in the States looking at the role of Confederates, and so this is just a brief comment to support what you've said, Michelle, that the effectiveness of that crossing other people's roles will really depend upon the purpose of the simulation, first point. But the second point is that there's some documented experience of very unhelpful repercussions of stereotypic, cliched performances, particularly of people who sometimes have less power in the healthcare team, where for example, nurses may be left to look rather silly and helpless, and we have to think about the implications of this, that surgeons in the scenario might be made out as very non-communicative and arrogant and assertive. Very unhelpful. So I think we have to look very carefully at the purpose of the simulation, just as you've said, Michelle, but to think about training people to take on roles of Confederates. And I know that this is time, so I'll close up. Thanks very much.
All right.
it's very easy for the whole thing to become a pantomime and then can be completely pointless.
Yeah. But I think what we've seen here, just to wrap up, is a very authentic representation of a simulation. And did you feel nervous? Was the adrenaline running?
Initially I felt nervous, but I think I got immersed in the simulation that I didn't even realise that Mum had come in. At the end I thought, oh, did you end up coming in?
Okay.
Yeah,
I think that happens. You become immersed in the simulation, it becomes real.
Yeah, yeah. And I think, just to take Deborah's point up, it doesn't have to be all, an academy performance. In fact, it's best if it's not. But trying to manage that up front is an important aspect, just to make sure people don't, go overboard and it becomes a little bit too theatrical. So thank you so much for participating and for Laerdal helping with all the setup. Pretty authentic ambulance officers bringing in the patient. And I'd like to thank you all for your participation. Did you enjoy it? Yeah?